It's a great pleasure to join such a distinguished group of, I would say, pioneers in this field to talk about the growth of services for LGBTQ plus community. Well, here I'm speaking to you from London Women's Clinic indeed, and as Sarah said, it's been around a long time. It's turning 40 this year, and over that period of time, and much of it over my career as well, it's been remarkable the changes that have happened in attitudes to treatment of LGBTQ plus community. But that hasn't just happened from talking about it. It's been about actions. And a number of clinics, again represented here this evening, have had an important role, like the LWC, in championing broader access to care. And LWC was there indeed from the very beginning. In fact, it was the first clinic in the country to interpret the welfare of the child clause that was put out by the HFEA in that time as being inclusive for LGBTQ plus community. I was working in the Netherlands at the time, where it was very, very normal to refuse same-sex couples, gay couples, even single women treatment for quite outdated reasons. And it has been remarkable to see the change over that period of time. But that has taken the courage and the initiative of many of the groups that you see represented here this evening to achieve that. So what I'm going to do over the next few minutes is just review some of the data that we have, outcome data on the treatments that are used, one of which is so clearly presented by Carol just now. And I think to set the scene, it's important to recognize the changes that we're seeing in the contribution of the LGBTQ plus community to the work we're doing as clinics. And this will be, I'm sure, representative of clinics across the UK. As we know, the HFEA has said that more single patients and female same-sex couples are having treatment, but disparities in access remain, and I'm sure we'll be discussing that later. In our own data, we see that, yes, heterosexual couples are still predominantly the group that we're treating, but same-sex couples and single women are forming significant groups of that. And perhaps what's hidden in this data, which I can show you here, is the remarkable growth that we've seen, for instance, in same-sex couples coming from IVF here at London Women's Clinic over the past 4 years, with a 90% growth. So a lot is changing, attitudes are changing. The efficacy of treatment is probably part of that story. And altogether, we're seeing this as becoming a very major part of the care which we provide. So I just want to touch on some of the treatments, because it's very important that we understand what the treatments do, how effective they are, and in which patients they're most appropriate. So let's start with the most simple one, which has been the backbone of treatment of same-sex couples for many years, and that is intrauterine insemination. And a few years ago, my colleague Elena Linara Demakaku, our embryology head, published this paper of a large study of 8,900 IUI cycles, of which 43% were carried out in same-sex couples, and was able to show that, as a form of treatment, this is going to be effective for many, as long as they stick with it. So particularly the under 35s, if they stay with them and don't drop out of treatment, around about 66% can achieve a pregnancy in this relatively simple way. But what we see from this kind of analysis, and this was, I think, the largest analysis at the time, was that the outcomes tend to plateau after 6 cycles. So this kind of data can help us counsel patients coming through as to whether or not this is the right treatment. And what we also see, perhaps unsurprisingly, is an age effect, such that in women above 40, only 3 cycles would normally be recommended before moving to other forms of treatment. So this kind of data is important that it's published, it's out there to guide counseling. Now, the other big change that's happened in more recent years has been this rise of inter-partner treatment, what's commonly known in the UK as shared motherhood. Again, I think LWC was one of those clinics that really got this moving about 15 years ago. And again, at the time, it was challenging a medical model of family building. I remember from my time in the Netherlands that the discussion with same-sex couples talking about this is, well, look, there's no medical need for you to carry the baby or for you to donate the egg, so we're not going to do it, which seems remarkably outdated now. And I'm glad to say it's largely disappeared. And in the meantime, we've been able to help carry out more than 1,000 embryo transfers for this. And we published outcomes from a large study showing that after 172 embryo transfers, very good cumulative live birth rates can be achieved. And the well-being of parents and children have been confirmed in follow-up studies working with our collaborators in Cambridge University. This is just an update showing the outcomes of even more cycles that we've done. And we're seeing, again, very high cumulative live birth rates. So these are realistic options for people to achieve the family in the way that they wish. Now, I'm just going to touch on surrogacy because it's been dealt in some detail, but just to report our own experience that we've had more than 200 surrogates coming through over the last 10 years or so, 140 babies very happily born from it. 46% of these are for LGBTQ plus patients. And in fact, what we're seeing in terms of egg bank, that the rise of same-sex male surrogacy is coming now. You can see in the table on the left there that heterosexual couples are still the majority, but same-sex male are really coming up now and forming an important group. And we're getting extremely good live birth rates in all of the groups. And if you look at, again, at the cumulative live birth rates, we're seeing excellent results across the board. So again, this is a very realistic, effective treatment for many, many people. Now, why am I focusing on clinical data? And I think it's because clearly we need to reassure prospective patients of the validity of the option that they're choosing. But also, I think having data from outcomes also supports the shaping and the arguing for policies, because if we can show that the treatments we wish to carry out for our patients in this community work, then it strengthens our position to shape policy. And this is an example, perhaps, of how we've been trying to do that here at LWC. So working with Kirsty Horsey, who, as many of you know, has been a leading advocate for change in the law around surrogacy, she joined us for a couple of years, and we published this paper of 179 cases, and we're able to draw some implications for policy and practice. These then extended into engaging in a debate as to the experiences of surrogates and intended parents, showing them to be generally extremely positive. And then from that, Kirsty published a couple of years ago this review article, which I would recommend, which is a review of the current global trends and national landscapes, and makes a very compelling case, in my view, for the change that we are seeking the Law Commission to bring in. And as co-chief editor of RBMO, I can't but fail to mention that this was the most clicked on article for our journal in the year it was published, showing the huge interest there is in reliable data-based information on surrogacy. Now, all of these techniques need to be mature before they can help transgender patients, and they are now. And this has allowed clinics like us to really start offering treatment to different combinations of families. And I've just listed some here. We've done 16 cycles where the patient was cisgender female and the partner was transgender male using donor sperm. We've done a cycle in a patient who was a cisgender female, the partner was a transgender female using IVF with frozen partner sperm. 2 cycles where the patient was a transgender male with a cisgender female partner. And indeed 1 cycle where both were transgender, a transgender male and a transgender female, using donor sperm and a surrogate. And again, if you persist with treatment in these patients, most of them will happily succeed. And that last case, if you're interested, we've recently published in RBMO, in which we described this couple, a 36-year-old transgender male who underwent preservation of their eggs and embryos in 2015, returned in 2018 with a transgender female partner. They underwent surrogacy treatment, a healthy baby was born, and I'm delighted to say another baby followed. So all of these techniques that we've been discussing come together to make this a possibility and hopefully a new normality on the UK fertility treatment scene. Now, as I started in my talk, we wouldn't be here without the courage of people to forge ahead with these treatments, sometimes against quite strong headwinds, whether that be regulatory or whether it might be interpretation of regulations or indeed groups with particular views on the matter. And it does take courage to lead, and I think London Women's Clinic has been one of those who's done that over the years. We've been very fortunate, I think, to operate in a very regulated environment, but one which keeps itself informed, it makes it very clear where the boundaries for care are, and is trying to be as inclusive as possible. And of course, that is the HFEA. And then to finish off with, of course, the Progress Educational Trust, which is such a strong and vocal and influential advocate for the LGBTQ plus community in fertility care, publishing courageous papers, such as this, again, from Kirsty Horsey and Zaina Mahmood, which I believe is making an important contribution to debate, and we all need to continue to do that.